discussion on surgery for tetralogy of Fallot. Tetralogy of Fallot is the commonest cyanotic congenital heart disease. Surgical repair has improved remarkably ever since it was first published in 1995 by Lillehei and colleagues. Excellent long-term survival is now feasible, with 30-year survival ranging from 68.5% to 90.5%. Symptomatic infants with tetralogy of Fallot can undergo either primary surgical repair or a palliative procedure, which could be either a systemic to pulmonary shunt or catheter-based right ventricular outflow tract or pulmonary valve dilatation. A retrospective study using the UK National Congenital Heart Disease Audit had 1,662 infants with mean age of 181 days from 2000 to 2013. Of these, 1,244 underwent primary surgical repair, 311 surgical systemic to pulmonary shunts, and 107 right ventricular outflow tract dilatation procedures. Mortality was higher in those who underwent primary repair before 60 days of age. Mortality at 12 years was 18.7% in those repaired before the age of 60 days versus 2.2% for those repaired after that. Right ventricular outflow tract dilatations were associated with more right ventricular outflow tract re-interventions and fewer pulmonary valve replacement at 12 years. They had lower mortality after complete repair. While considering procedures in early life, each has its own disadvantages. Early primary repair can increase the need for transannular patch and late morbidity, mostly due to pulmonary regurgitation. Surgical shunts have high rates of complications, while right ventricular outflow tract dilatation procedures are associated with valve lesions and re-interventions. Shunt surgeries are usually done as palliative procedures prior to surgical repair of cyanotic congenital heart disease to improve the pulmonary blood flow. Classic Blalock-Taussig shunt was devised by cardiologist Helen B. Taussig and cardiac surgeon Alfred Blalock as a palliation for cases of tetralogy of Fallot. The subclavian artery is divided and anastomosed to the pulmonary artery as an end-to-side anastomosis. Usually it is done on the side opposite to the aortic arch because of the presence of the brachiocephalic trunk on that side prevents kinking of the subclavian when it is pulled into the thorax. Unilateral rib notching due to collaterals, which develop to supply the arm, can be seen in those who have undergone the shunt after several years. In modified Blalock shunt, a Gore-Tex graft is used to connect the subclavian artery to the pulmonary artery. Both these shunts are done to the branch pulmonary artery on the side of the shunt, and approach is through a posterolateral thoracotomy. Schematic diagram of a modified Blalock-Taussig shunt in a person with right aortic arch and tetralogy of Fallot is illustrated here. Waterston shunt is one of the older central aortopulmonary shunts connecting ascending aorta to right pulmonary artery. Central shunts have a higher chance of producing pulmonary hypertension later. Potts shunt connects the descending aorta to the left pulmonary artery. Both these central aortopulmonary shunts are side to side and prone for development of pulmonary hypertension and pulmonary vascular disease. They are only of historical interest. The initial surgical repair was by a ventriculotomy approach in the right ventricular anterior wall, and transannular patch was used to relieve right ventricular outflow tract obstruction if needed. 26 to 31 year follow-up of the first 106 patients was published in 1986. They mentioned that the first surgical correction was done on 31st August 1954. Initial 6 patients were operated by cross circulation and remaining 100 patients with bubble oxygenator. They noted that actuarial survival at 30 years was 77%. Actuarial freedom from reoperations at 30 years was 91%. An excellent aspect is that 32% completed college, 5 took master's degrees, 2 MDs, 2 PhDs and 1 lawyer. 40 patients had progeny with 93% live births and 6 major cardiac defects. To avoid a ventriculotomy, transatrial and transatrial transpulmonary approach is currently preferred for repair of Tetralogy of Fallot. In a long-term follow-up data of 453 patients who underwent transatrial transpulmonary repair at a median age of 0.6 years, survival was 97.3% at median follow-up of 14.3 years. Transannular patch was used in 65% of patients, though use declined over time from 89% initially to 64% later. Primary outcome measures in that retrospective analysis were death, pulmonary valve replacement, re-intervention for other reasons, and implantation of a cardioverter defibrillator or pacemaker. The use of a transannular patch was a predictor for poorer event-free outcomes with 1.7 times risk of composite endpoint. Overall, 52 patients underwent pulmonary valve replacement and 5 had pacemaker insertion during follow-up in the study.